Good morning and welcome. I'm Anna Fisher, and my role here today is the moderator for this grand event. I want to extend a warm welcome to our distinguished panel experts and as well as the esteemed audience members. We thank you for taking the time to share in this grand event. And with that, I mean how wonderful it is to have a morning of learning on topics of dementia and neurological conditions, and that we have the area's top leading experts in dementia and neurology here to share their wisdom, their expertise, and their knowledge with that. I would also like to extend a very big special thanks to Dr. Mary Hawkins, President of Bellevue University, and her team for graciously allowing us to host the event in this beautiful auditorium. The event, this is our first annual Neurological Forum, sponsored by Hillcrest Home and Community Services, so we hope to continue this on annually. At this time, I'd like to introduce Carrie Inzalera, who is our Director of Marketing for Home and Community Services. Carrie and her team, as well as Jim Janecki, our Vice President of Marketing, and Krista Roberts at Hillcrest Health Services have been instrumental in coordinating such an event like this. I also want to make note that the panel experts, as well as their presentations, will be videotaped, and a link will be available on Hillcrest Health Services for your future reference. So with that said, I'm going to turn it over to Carrie Inzalera, and she will start the formal introductions of the panel experts. Carrie?
Thank you so much for coming today. We're very lucky to have such a panel of experts here to talk to us today. I'd like to introduce Dr. Deborah Hoffnung. She is a clinical neuropsychologist with Alegent Creighton, so we're very pleased to have her. Thank you very much. We have Dr. Rebecca Reilly. She is with Methodist Health System. She's medical director of Methodist Geriatric Clinic. We're also lucky enough to have her as our medical director for both Hillcrest Home Care and Hospice, so thank you very much for being here. Dr. Daniel Murman. He is Associate Professor and Interim Chair Director of Behavioral and Geriatric Neurology Program at the University of Nebraska Medical Center. So we're very lucky to have him as well. Thank you. And then Dr. Scott Deasing is not here yet. He will be here in just a little bit. He is currently a partner physician at Neurology LLP, so he will be here in just a few minutes as well. As Anna mentioned, the PowerPoints that go along with this, plus the videotape, will be available on Hillcrest's website middle of next week. So I hope everybody learns a lot today. Thank you so much for coming. We greatly appreciate it.
Our first presenter, Dr. Deborah Hoffnung.
Good morning, everybody. Okay. This morning we're going to be talking about a lot of different kinds of dementias, and let me know if you're hearing me well, not hearing me well, if I'm speeding along too much. But my role today is going to be to talk to you about a particular type of dementia, Lewy body dementia. And so we're going to talk about why even talk about different kinds of dementia. Used to be, and most patients that I'll see will come in and say, my family member had Alzheimer's disease. In fact, we now know that not everybody who had Alzheimer's disease actually had Alzheimer's disease. And being able to differentiate between the different kinds of dementias is very helpful and very important. I'm going to review some important terms in speaking about dementias, get into a review of Lewy body dementia and the diagnostic criteria, a little bit of the histopathology or what it is that makes Lewy body dementia, differential diagnosis, and then treatment. I'm not going to spend too much time on that because I am a clinical neuropsychologist and not an MD, so I don't do any prescribing. So why talk about different kinds of dementias? Well, again, not all dementias are Alzheimer's disease. And diagnosing the other common causes of dementia requires clinicians and nurses and nurse practitioners and clinics to ask about non-cognitive symptoms. A lot of the differentiation between the different kinds of dementias is in the pattern of cognitive changes, but also in the non-cognitive symptoms. And developing a broader understanding of how to identify and manage the symptoms of different types of dementia gives us places and venues to intervene. So non-cognitive symptoms often do respond to interventions that may lead to improvement in the patient's and the family's quality of life. Okay. When we talk about dementia and we talk about Lewy body disease, there's some terms that we throw around. So just to make sure we're all on the same page, when we say dementia, we're talking about a loss of mental function severe enough to affect normal activities and relationships. This isn't misplacing your keys or going into a room and forgetting what you've gone in for. This is really loss of ability to function in day-to-day activities and family activities at work, etc. When we use the term Parkinsonism, we're talking about symptoms that are seen in Parkinson's disease, but not only or not unique to that disorder. So Parkinson's-like. Sensitivity, we'll talk a little bit about accuracy or sensitivity. That's the true positive rate. So if I have a test and I'm looking for a particular disorder, my sensitivity is the actual number of true cases that my test picks up. And specificity is the true negative rate, or the actual number of non-cases that my test says, nope, that's not it, okay? And then the term pathognomonic is the word we use for symptoms that are characteristic for that particular disease. So these are the highlights, these are the red flags that tell us that we might be looking at this particular disorder. Okay, so, Lewy body dementia, also called dementia with Lewy bodies, was first discussed by Okazaki in 1961 in a case report of two patients who were 69 and 70, gentlemen who presented with dementia and died soon after with severe extrapyramidal rigidity, okay? The autopsy showed Lewy body pathology, where Lewy bodies had been a particular type of cell abnormality found in the brains by someone named Lewy, who happened to have been doing work in Alzheimer's lab. And now, 15 to 30% of all the dementias we believe are caused by Lewy body dementia. And it's found in up to 20% of all the cases of our elderly demented patients who reach autopsy. So we believe it's the second most frequent neurodegenerative disease after Alzheimer's disease. It's not a zebra, it's more common than we think it is. Onset and course of Lewy body dementia, the mean age at onset and survival are similar to Alzheimer's, between 60 and 85 years. However, Lewy body may progress more rapidly. We'll speak a little bit about the sensitivity of Lewy body dementia patients to particular medications, and some theories say that perhaps it's treatment with these medications that may be what's causing the rapid declines. Average lifespan after onset is 5 to 7 years. Early on, we typically see more of the cognitive and psychiatric symptoms. And then the condition progresses to a more severe dementia, immobility, and then death, usually from pneumonia or other illnesses, so similar to Alzheimer's disease. When we're diagnosing Lewy body, there's been criteria developed by the Dementia with Lewy Body International Workshop. The central feature of Lewy body dementia is a progressive dementia. And then the core features, there's 3 core features: fluctuating cognition with pronounced variations in attention and alertness, so changes day to day or within a day in a person's level of alertness and attention. Recurrent complex visual hallucinations, which really is one of those pathognomonic signs for Lewy body dementia, and then spontaneous features of Parkinsonism. Suggestive features are a REM sleep behavior disorder, and that can appear years before. And so we're going to talk specifically about what each of some of these core and suggestive features are. Severe sensitivity to neuroleptics in up to 50% of individuals with Lewy body. And then on some specialized neuroimaging studies, low dopamine transporter uptake in the basal ganglia, in the motor areas of the brain. Okay. Supportive features are repeated falls and syncope, transient unexplained loss of consciousness, autonomic dysfunction or changes in blood pressure regulation and things like that, hallucinations in other modalities beyond the visual modality, visual spatial deficits, so changes in depth perception, object orientation, direction sense, illusions, or seeing a coat on a bed and seeing it as a dog, and then other psychiatric disturbances, delusions, aggression, depression. In order to make the diagnosis of probable Lewy body, we are looking for dementia plus 2 or more of those core features, the fluctuations, the visual hallucinations, and the spontaneous Parkinsonism. Or dementia plus 1 core feature and 1 or more of the suggestive features. And then possible Lewy body dementia is dementia plus 1 core feature or dementia plus 1 or more suggestive features. So this is really research focused. When we're doing a study and we're looking at Lewy body dementia, to really categorize people, we're putting them according to this diagnostic criteria. Talking about our accuracy. Those criteria are what's called the McKeith criteria, and the criteria have pretty high specificity. So about 95% of the time, we identify somebody as having Lewy body dementia. Our sensitivity in a perfect sample is about 83%. But in a large cohort, we miss a lot of people. So it was 32%, 68% false negative. So in that group, we missed 68% of the people who would have met the diagnosis based on autopsy. And when there was Lewy body mixed in with Alzheimer's pathology, the sensitivity was only 12%. So in other words, the majority of patients with Lewy body dementia are actually not being diagnosed, and that's one reason we talk about it. So let's talk about some of those clinical features. The pattern of cognitive impairment in dementia with Lewy body, individuals have particular difficulties in attention, in executive functions like planning, prioritizing, sequencing, self-monitoring, visual spatial problems, route finding, clock drawing, figure copying. But the core feature, again, is there's a fluctuation in cognitive performance from one day to the next. So when we see patients with Lewy body, their family members will often say they have good days and they have bad days. They have mornings where I feel like they're really there, and then afternoons where they're completely disoriented. Okay, and that's really a core feature of Lewy body. Visual hallucinations, and I have a little something there to remind me. Visual hallucinations is one of those pathognomonic signs. We know psychiatrically that onset of something like schizophrenia, new onset in somebody's 70s or 80s is very rare. And in fact, visual hallucinations is more suggestive of dementia or a neurological disorder in older age or a medication side effect than it is of a psychiatric diagnosis. Visual hallucinations occur in up to 80% of the patients with Lewy body, and typically they are recurrent, well-formed, complex, and detailed. So they're people or animals. They're not always distressing, and they're sometimes accompanied by delusions, particularly persecutory delusions. I have a cat there because this may be because I am aware and a cat person, or it may be an interesting phenomenon, but anecdotally in my experience, I see a lot of patients who have visual hallucinations of cats. In fact, I recently had a patient who believed that there were cats in her home and in her fireplace, and there was no amount of convincing her that there weren't, and she even snuck some cans of cat food into the shopping cart when they went shopping because she firmly believed there were cats and they needed to be fed. I've also seen people who believe that they have family members or children staying in the house, and rather than being distressed by it, what's distressing to them is how are they going to feed them? How will there be enough food to feed the children who are visiting the home? We can see visual hallucinations and fluctuating cognition in Parkinson's disease due to side effects of the Parkinson's medication. So that would be one consideration if we know someone has Parkinson's disease. The consideration would be if they're on anti-Parkinson's medication to potentially do a trial of reducing their dose or withdrawing them to see if the visual hallucinations go away. When we speak about Parkinsonism, the symptoms we're really talking about are rigidity, bradykinesia or slow movement, changes in gait and reduced arm swing, that mask-like faces or really sort of a flat, non-smiling, non-frowning facial expressions, and a tendency to falls. Less frequently do we see that unilateral resting tremor that comes on more typically in Parkinson's disease. And we see these symptoms because the pathology is in the similar area as Parkinson's disease, but it is not the same disease. The 1-year rule of thumb is if dementia develops within 12 months of those Parkinson's-like symptoms, it's suggestive of Lewy body dementia, whereas if the motor symptoms exist for longer than about a year and then dementia comes on, it's more suggestive of Parkinson's disease with later developing dementia. So the distinction there is the primary feature in Lewy body is really the onset of dementia closer in time to the onset of movement problems. When we talk about neuroleptic sensitivity, what we mean is a severe sensitivity to antipsychotics in about 50 to 60% of patients with Lewy body dementia, where they'll develop Parkinsonism even if they have had no signs of those motor issues before the drug was started. We may see extrapyramidal signs, rigidity, sedation, or even immobility. And the worst case, a very significant, potentially fatal syndrome would be the neuroleptic malignant syndrome, where treatment with the older antipsychotic drugs might bring muscle rigidity, fever, autonomic instability, and delirium and muscle breakdown that can lead to death. So it's a very significant potential reaction to these medications that patients with Lewy body dementia seem to be more prone to. What is Lewy body? It is a synucleinopathy. And basically, that means it's an abnormality in a type of protein in the brain. And so Lewy bodies are these tiny spherical deposits of this protein that develops inside the nerve cells and interferes with their functioning and looks a little bit like that little spot right there. Lewy bodies, in fact, are present in other diseases, and there's a whole spectrum of diseases in which that protein abnormality is found in the brain. We do find Lewy bodies in individuals with Alzheimer's disease and Parkinson's disease, and all of these other dementias and neurological conditions, and really the difference is In Lewy body dementia, the Lewy bodies are present in both subcortical and cortical areas of the brain. And in Parkinson's disease, those Lewy bodies tend to be primarily subcortical, so in the motor areas of the brain. In Lewy body, neurotransmitters are also diminished, so we see decreased acetylcholine, and in fact, it may even be worse than the decrease that we see in Alzheimer's disease. And we also see changes in dopamine and dopamine transmission. Differential diagnosis. Someone comes in, what else could it be? Or is Lewy bodies in the line of differential diagnoses of other things like Alzheimer's disease? So patients with Lewy body dementia have more trouble with their executive functions, the planning, the organizing, the self-monitoring, more trouble with their visual spatial functions, and less trouble with naming and memory. Practically, is this necessarily something that's going to be clear in a clinic? No. We're talking about large patient groups. However, the pattern on neuropsychological testing would probably be more difficulty on the executive and visual spatial functions, and naming and memory not so bad, to the point where you would say, if this was Alzheimer's, I really would have expected their naming and their memory to have gotten a lot worse before I saw some of these other difficulties. Visual and auditory hallucinations are more common in Lewy body than Alzheimer's. That fluctuating cognitive performance really leans us more towards the diagnosis of Lewy body. Greater sensitivity to the neuroleptics and the Parkinsonian symptoms are really what sway us more towards Lewy body and less towards Alzheimer's disease. Another common differential diagnosis would be Parkinson's disease with dementia. And so our Lewy body patients actually respond less well to Sinemet, to the levodopa-carbidopa, and typically show an earlier dementia onset. Additional differential diagnoses would be things like other dementia syndromes. We can see motor changes with vascular dementia, or some of the Parkinson's plus dementias like PSP or multisystem atrophy. Normal pressure hydrocephalus might be a consideration because there's gait changes and there's cognitive changes. A delirium, those visual hallucinations, could be more of an acute delirium, or a psychiatric disorder, particularly if there's a past history of psychosis or schizophrenia. So why worry about differentiating Lewy body from the other dementias? Early treatment of dementia and the psychiatric symptoms may slow the progression and improve quality of life. Individuals with Lewy body dementia, caregivers of individuals with Lewy body dementia actually seem to have more caregiver stress than individuals with other dementia, particularly because of the psychiatric symptoms. We would want to know that there was a Lewy body present because we want to avoid medications that can aggravate the symptoms, like neuroleptic medications. And we would want to know the particular diagnosis to allow the family to plan for that expected decline and improve safety in the home. Management. So this is what I'm going to breeze through a bit. Individuals with Lewy body dementia may respond a little better to some of the acetylcholinesterase inhibitors, or the medications that stop the body from taking away the acetylcholine. It makes it last longer for the neurons. Cholinergic deficits, because the acetylcholine deficits seem to maybe be more significant or more marked in Lewy body dementia, they may respond better to the medications that are used than even Alzheimer's patients. There's not a lot of evidence to say that one medication is better than another, but all do seem to improve or at least stabilize cognitive and neuropsychiatric measures and help to stabilize the motor functioning. Ribostigmine, donepezil, galantamine, all have been used and shown to be the same level of efficacy as used in Alzheimer's disease. There haven't been a lot of studies using memantine in these individuals. A small proportion of patients, that acetylcholinesterase inhibitor might actually worsen their motor functions, and for them, atypical neuroleptics are recommended, particularly for managing the psychiatric features. So risperidone, olanzapine, quetiapine. Levodopa, carbidopa may improve motor functioning, but typically does not, and may exacerbate the psychiatric symptoms, the visual hallucinations. And then SSRIs, depression may result from the pathology of Lewy body dementia, and also that psychological response to impaired function, and SSRIs have been used in these patients. Treatment of the REM sleep behavior disorder, what that is vivid dreams and acting out of dreams. So typically I'll ask my patients, spouses or significant others, are you getting punched in the nose, or are you getting hit with a lamp? Because individuals with REM sleep behavior disorder, which is also common in Parkinson's disease and dementia, typically will be very active, have very active dreams, and act out their dreams. And then clonazepam is typically used. Non-pharmacological treatments include education of the patient and the caregiver, support groups. There is a Lewy body dementia organization, structuring of the environment, ensuring that there's adequate lighting, physical therapy and gait training for the motor difficulties and the gait difficulties and tendencies towards falls, and then improving sensory impairments, again making sure that hearing and vision are adequately corrected. Sort of getting towards the end, summing it up, these are hallmark symptoms that should make you suspect maybe this is a Lewy body dementia. Dementia is usually the presenting feature, and it's usually more severe with the attentional, visual perceptual, and visual spatial dysfunction. And so if you have an individual coming in saying that they've had some recent scrapes or fender benders, not quite getting the car lined up to get it into the garage, or misjudging how much time they have to cross over a lane, that would make me suspect the possibility of dementia, particularly Lewy body dementia. If there's fluctuations in functioning, so you're hearing about those good days and those bad days. Visual hallucinations, particularly cats. Again, my anecdotal evidence, but if someone comes in, tells you they think they're seeing cats, I would suspect Lewy body dementia, unless you're know me well, and I'll show you an example of that. Behaviors during sleep, like vigorous movements of the arms and legs with vocalizations. And then if Parkinsonism is present, less resting tremor, more of a symmetric onset, and a poor response to levodopa and recent falls. So all of these in Sorry. Just to make sure you're still with me. Any of these in a history would make me stop and think, is this potentially a Lewy body dementia? And as you can see, some of these symptoms may not be things you would think to ask about when you are meeting with someone who has memory concerns. And so, summing up, this cartoon here is a good reminder. It says she only thinks she's a crazy cat lady. We don't actually have any cats. And there's a lady here putting out lots and lots of bowls of cat food. But the caveat is, I am a crazy cat lady. I have 3 of my own, and I'm currently fostering a mother and her 5 babies. And on Saturday, I'm driving to Rockport to pick up a cat in an Underground Railroad adoption. And bring it through to Omaha. So you want to know your patient's prior social history because I'm thinking when I'm about 60 or 70 and I'm putting out bowls of food, it's likely because there really are 9 cats in my house. I think that's all I have. So thank you very much.
Thank you, Dr. Hoffnung, for that wonderful presentation. A couple of things I wanted to make mention before I introduce our next speaker is, for those of you, please, who have the CEU forms, please make sure the form is filled out in its entirety and you have your license number on there as well to make sure that paperwork gets processed accordingly. And also the structure of today's event is each panel expert will present approximately 30 minutes, and then at the conclusion, we will have a question and answer forum. So at this time, I'd like to introduce Dr. Rebecca Reilly, geriatrician, and she will be talking about frontotemporal dementia. Thank you, Dr. Reilly.
Thank you, Anna. All right, let's see if I'm all wired up here. Whoops. Well, that's not going to work. All right. Well, thank you all for being here this morning. As everyone has said, I'm Becky Reilly. I'm a geriatrician. I work at the Methodist Geriatrics Clinic, and we do assessments of patients there. We've been in operation for almost 19 years, and we see about 100 patients a year. So we've seen a lot of patients, the majority of whom have dementia. I wanted to talk about frontotemporal dementias today because this is one of the areas where I see families and caregivers get the most frustrated and get the most mixed messages from their health professionals. The problem with patients with FTDs, and I'm going to call frontotemporal dementia FTD because I cannot say frontotemporal dementia 30 more times in the next 30 minutes. So, and not to be mistaken for STDs, that's a completely different talk. People, oftentimes, if you go see your primary physician and your wife has made you go because there's something wrong, and you're talking to the physician and you guys are having a great time because FTD patients tend to be a lot of fun, your physician will do a memory test and you'll do fine on the memory test, and they'll say, oh, there's nothing wrong with you. And I'm going to talk quite a bit about this to try to explain what the symptoms are and why this is so challenging. Oh, there we go. No. I'm hoping you find me much more scintillating than these ladies did. I was going to talk just a little bit as a clinician about Lewy body dementia, but I think Dr. Hoffnung covered pretty much everything. Just the motor issues, you're going to see people who are stiff and slow more than anything else, not too much tremor. Cognitive issues occurring within a year. About 25% of people with Parkinson's disease wind up getting dementia, but it's usually years down the road. Hallucinations, usually visual hallucinations. In a minority of times, people will have auditory hallucinations, or sometimes they will smell things. That they will hallucinate smells. That's very rare, but something to be aware of. The sensitivity to antipsychotics, I found out the hard way. When I was in training, which was a very long time ago, Lewy body disease wasn't one of the main dementias that was covered. This was something that kind of came along after we'd started the clinic. But I remember very clearly a patient, probably the first person that we identified in our clinic with Lewy body disease, and he was having horrible hallucinations, no cats at all. He had tanks and soldiers in the backyard. And so I gave him just a little tiny bit, and this was a really long time ago. It might have been Haldol. I think it was before Zyprexa, Risperidol, Quetiapine, any of that came out. And I gave him half the smallest dose, which is what we do in geriatrics, and they couldn't get him out of bed for 3 days. So that was how I learned about this myself. And the fluctuation, all patients with dementia have fluctuations. There'll be days when the caregivers will think, oh, I was completely wrong, everything is great. And then the next day, they'll know that they were right in the first place, there really are problems. In Lewy body, the fluctuations can be even closer together. You can fluctuate hour to hour, sometimes minute to minute. And as far as treatments, again, Dr. Hoffnung did a good review. Physical therapy for the patients with the motor problems, that is the first thing I do for people with Parkinson's disease or with Lewy body. Falls and problems with balance tend not only to cause injury, but make people's worlds get much smaller. And so if we can get them working and active and moving around, that improves their quality of life despite this disease. We obviously don't have anything that's curative. Antipsychotics are associated with a higher risk of death in older people with dementia of all types. So we really need to be careful about giving people antipsychotics to deal with their hallucinations. So if they have, if Deborah gets cat hallucinations and thinks she has 12 cats instead of 9, that's great, it will just make her happy. But if she thinks someone is coming to steal her cats, she'll be very distressed, and so we may end up needing to medicate those hallucinations. Antidepressants, I think, are good for everybody. I'll talk about that more later in the presentation. That maybe I'm just speaking for myself, I don't know. But when I did primary care and would be on call for the weekend, I would dream of putting antibiotics and Prozac in the water system and how much better that would make my weekend go. And then Dr. Hoffnung did a great job on reviewing the memory medications. And the important thing that I just want to mention to everybody who takes care of people with any kind of dementia is the memory medicines don't fix memory. They help keep you from getting worse. They do not make things better. When people get better after I've started memory medicine, I love to take the credit for it. But really, it's probably that the family's paying more attention to them. They're getting more support. Everybody gets an exercise plan when they come to see us. Those are the things that I think actually make people better. So I want to do just a little review for the FTD. These are some stylized pictures of the brain. Let's see if I can make this. There we go. So we're really talking about diseases that affect the front of the brain and then the temporal lobe of the brain. And this is as though we cut the brain in half and looked inside of it. That's the inside. The temporal lobe is around the outside, kind of above the ear. And then the frontal lobe is what's over and around your eyeballs. With the behavioral symptoms that we see in frontotemporal dementia, which I'll talk more about, those are primarily frontal. The memory problems we get are primarily temporal. Language problems are some of both. There's a speech area that's right down, kind of in that corner down there, that is important in allowing us to express ourselves. And when that is not working well, then we have a great deal of difficulty. So the frontal lobe functions include personality. That's I did geriatrics before I had kids. So my poor children, they've had the mini mental status exam done because I wanted to know if a good student in 3rd grade could do serial 7s. So, and they've had a variety of reflexes and things done. But I also noticed when I was bringing them up that what I was really doing was civilizing their frontal lobes. And you watch the personalities develop as people grow up, and certainly we change as we age and we're exposed to different people in our lives in different circumstances. But the personality is in the frontal lobes, and often that's the first sign that there's something wrong in FTD, is that the personality is changing. Most of the time, it is not for the better. Once in a while, we get people who've been really grouchy and unpleasant, and their families go, "This is great. She's so mellow and so nice now." So all change is not bad. Judgment is in the frontal lobes, and inhibition is a huge area here. And inhibition and judgment are, two sides of the same coin. If you have an idea that you would like to get in your car and drive to Vegas for the weekend, but your daughter's getting married the next day, and I'm sure there are plenty of people who've had that thought the night before the wedding, but you need to use your judgment and inhibit that impulse. But judgment is also, do I have enough money that I can afford to go on QVC and buy whatever I see that I want? Or do I have enough enough money to be able to give $20,000 to the Audubon Society, which anyway, so there are all kinds of things that we need to make judgments about that happen, and that happens in our frontal lobes. Motivation also comes from the frontal lobe. So all of you have functioning frontal lobes because it is 9 o'clock in the morning and you are here sitting listening instead of watching. Actually, I don't know what's on TV at 9, but instead of watching TV and drinking coffee and eating bonbons at home. You have to have the motivation to get up and get going and get things done. And if your frontal lobe doesn't work, that doesn't happen. The ability to organize. The examples I use when I'm talking to patients and families are, for instance, if somebody is going to build a shed. And I think of this because I had a patient who built a shed for about 1.5 years because every day he'd go out and fiddle around and move the wood here and move the wood there and maybe cut one thing here and then, but he could never get the steps organized to actually put the shed together. Also, cooking dinner is a highly organized task, as probably everyone in this room who's put a meal together knows. You have to think about, okay, what are we going to have, and hopefully plan a nutritious meal, and this is going to be done, this takes this long, and so I have to start this first and then add this on. And so these are things that we see patients lose as their frontal lobes stop working, is mom used to be able to cook Thanksgiving dinner for 27 of us every year for 20 years, and all of a sudden she can't remember how to make this, or the turkey wasn't done, or something like that. And social awareness is another big one, and this is where we see inappropriate behavior. And you've all seen it. We'll talk more about it, too. Now, there are in the literature, there are up to about 8 different kinds of FTD. I'm going to concentrate on these 3 because these are the ones that everybody seems to agree are part of it. The behavioral variant is the one that we see the most, and the ones that as caregivers and professionals you will probably see the most because it is very challenging for caregivers to take care of people with FTD at home. There are psychiatric symptoms similar to what Dr. Hoffnung was talking about with Lewy body disease. People will be impulsive and embarrassing in public and difficult to maintain, and then they can get to the point where you just can't get them to do anything. So those patients end up needing professional assistance sooner than some others might. Progressive non-fluent aphasia and semantic dementia are both language issues that I'm going to talk a little more about. So with the behavioral variant, we see loss of the things that I just talked about that the frontal lobe does. There's a loss of inhibitions and social awareness. One of my very memorable patients with FTD was this beautiful, lovely lady whose husband brought her in, a wonderful, devoted man, brought her in because she just wasn't acting like her normal self. They lived in a small town, and they lived on the golf course in the small town. And she would go out. They used to, after the golf course closed down, they would go out and find lost golf balls. Well, she started wandering out on the golf course during the daytime and picking up balls that were in play. This made golfers very unhappy. But they also would go for meals up to the clubhouse at this club, and she would go around and talk to people whether she knew them or not. And she was not, I've had patients who've eaten off strangers' plates. She's not one of them. But just the whole loss of what's appropriate and what's not become very blurred. Impulsivity, like I talked about, I think I'll go to Vegas, okay, I'm gone now. Or it's not only doing things, but saying things. And families often have very hurt feelings because, you know, mom will say, well, your sister was always my favorite. Or, aren't you ever going to lose some weight? Or something very cutting that they never would have said if they had their filters in. Lack of motivation I've talked about. People, you can't get them to exercise. You can't get them to get up and go take a shower. You just can't get them to do much of anything but sit in the recliner and eat and watch TV. Hyperoral behavior includes not only in very advanced disease putting unusual things in the mouth, but also eating and eating unusual things. This beautiful lady that I was talking about gained about 30 or 40 pounds during the course of her illness because eating sweets is something that people do. We see that in Alzheimer's disease, but we also see it a lot in FTD. And this lady, her husband came in and said she wants jelly on everything. She put jelly on salad. And when you put sugar or extra calories on everything you eat, pretty soon that's going to catch up with you. And sexually inappropriate behavior, we do occasionally see patients who have very overt inappropriate sexual behavior. More often, or at least among the patients that I've seen, it is an issue of not knowing boundaries. Again, this lady would go to the country club, and she thought she should know everyone. And so she'd go up to men she didn't know and kiss them, or men she barely knew, and say, oh, hello, and give them, not a sexual kiss, but just a friendly kiss, and this made a lot of people uncomfortable. But that's something that we see, and again, it's extremely distressing. With progressive non-fluent aphasia, it's also known as primary progressive aphasia, and that's what I'm going to call it because that's what we call it in clinic when we see people. And it's a gradual loss of ability to express yourself. It starts off as just not being able to find quite the right word, but pretty soon you can't find any of the right words. You can't put the sentence together. It's called expressive aphasia when that happens. And later in the disease, receptive aphasia happens too, where you can't understand the words that people are saying to you. And it's not just the spoken word, but also the written word. In semantic aphasia, people can talk. They just say words that are not the appropriate word. They might, instead of saying, I'm going to the grocery store, or I need to go to the grocery store, they might say, well, I need to go to that place where, they have the milk and we could get bread, and not ever come up with quite the right word, or put in another word. Instead of grocery store, they might say the gas station. And families are actually pretty good at following this usually, but sometimes it gets very challenging to communicate. As far as FTD, it is more often early onset, and that's in people in their 40s to 60s. Of all the people with dementia of any age, it's about 12 to 15%. And we probably see just a slightly higher percentage in our clinic because people with plain garden variety Alzheimer's disease, of whom there are tens of thousands in town, are likely to be taken care of by their primary care physician. 30 to 50% of early onset dementia patients, those under the age of 65, are going to have frontotemporal dementia. It's the second most common early onset dementia after Alzheimer's disease. And when you go to the older ages, it is a smaller percentage, and it's the third most common after Alzheimer's disease, Lewy body, and then comes FTD. A lot of the cases are genetic, and this is something that's kind of exciting. The research is happening now. It's actually been within the last, probably been within the last 15 years that we started seeing at the national meetings people talking about frontotemporal dementia, and within the last maybe 8 years they've said, aha, it's a tau protein problem, which I'll talk about a little bit. About 5 to 10 people per 100,000 have it, and men and women are equally affected. Now, this is taken from a publication, the author was Barbary, and comparing the younger onset up to 60 and the older onset. In the younger onset, of whom I see very few, the memory loss, only 36% of people have memory loss. And basically, every patient I've seen with frontotemporal dementia, because I see older patients, gets memory loss at some point. And I also thought it was interesting when you scan these people, the younger people have more atrophy than the older people. And I think this is atrophy attributable to the disease. Atrophy is shrinking of the brain, which you see on scan. We all start having our brain shrink when we're in our 20s. So by the time we get to be 70, there's already been a fair amount of shrinkage. FTD, I think, is going to turn out to be, well, it obviously has many variants. It's probably going to turn out to be a whole lot of different diseases. Again, back when I was in training, we didn't have FTD. Everybody with FTD was lumped in with Alzheimer's disease. So I think this is going to be split out more. Tau is a protein that is important in Alzheimer's disease as well. In Alzheimer's disease, we have amyloid plaques and neurofibrillary tangles. The tangles are made of tau. Ubiquitin is another substance that gets into inclusion bodies and gets in cells and messes up their function. The most common mutations that we know about so far are on chromosome 17. And survival in FTD is shorter than we see in Alzheimer's disease. Average is 6 to 12 years. People are tremendously variable. Sometimes something happens, and they end up passing away earlier. And sometimes they live longer than this, but generally 6 to 12 years. Now, I just want to differentiate the two language variants of this a little bit for you. In primary progressive aphasia, what I usually see is patients who come in and they are so frustrated and irritated by their inability to express themselves. They know there's something wrong. They don't have memory problems early in this disease. It's not till later. And so they will complain that they can't say what they want to say. In semantic dementia, sometimes the patients have the complaint. Sometimes it's the family saying, I'm having such a hard time understanding what mom is trying to say. In PPA, people eventually stop talking altogether. Not so in semantic dementia. Both of them develop memory problems. And I have found with PPA, and I have to say I've seen a lot more PPA than I have the plain semantic dementia, speech therapy will help briefly, early on in the disease. We can send people and we'll get, they'll go through treatment for a few weeks and we'll get a few months of benefit out of that. The other thing speech therapists can do is give people an alternate way of communication, either using boards with pictures on it, or there are electronic things which don't work that well with older patients, I've noticed, but with the younger onset patients, electronic speech aids that can be helpful. And I've really talked about a lot of these symptoms. One of the main things that we'll see, though, is irritability, where people just get shorter fused, and that's part of when people say things that they might not have said before. Sometimes it's because they're irritable, sometimes it's because they have no filter. Inappropriately friendly, the spending. Pseudobulbar affect is something that's what we call kind of a disconnect between emotions and affect. Affect is what you look like and sound like when you're saying something. So somebody could be smiling and telling you about how their husband died and their best friend died within 2 weeks of each other. Or somebody could be talking about how what a good time they had at their grandson's baseball game and be crying. So there's a disconnect for that, and there's a new drug for that. That's why people are starting to know that phrase, because the marketers are out. So I haven't used the drug yet. I don't know if it's any good. I just vote for being careful. Now, perseveration is the other thing I want to mention. Perseveration is something that we call a frontal function. It's when somebody gets on something and won't get off. So usually if somebody starts to get upset, I'm sure all the people in this room who take care of people with dementia know that if something is starting to bother somebody, you distract them. You take them off to do something else. Sometimes it's really hard. This week I saw a patient who had given her niece her watch to get a new battery in. And this lady cannot remember a conversation 2 minutes later, but she remembers she needs that watch back. And so every time the niece sees her, she asks her, I don't know why the niece didn't just go get the watch battery the first day. That's what I would have done. But it's a constant thing. And especially something that's emotional or upsets people, they will kind of stick with. As far as medications, SSRIs are the and they're SSRIs, SNRIs. There are several different antidepressants that can be very helpful. First of all, these drugs, and I'm talking about Prozac, Zoloft, Paxil we kind of avoid because of its cognitive effects, but it can be very calming. Mirtazapine is one that or Remeron is one that I like to use for people who aren't sleeping well, and it's also very calming Wellbutrin is activating and is something that helps when people don't have much motivation. These medicines tend to be very helpful in a variety of symptoms. Atypical antipsychotics, sometimes we have to use. It was our treatment of choice before all this really annoying stuff came out about how it can cause death. We went to it a lot sooner. Whoops. Oops, I'm sorry. The memory medicines, I'll talk about mood stabilizers, and then there are a couple of miscellaneous meds. So SSRIs decrease disinhibition and irritability. They may also help with the sexually inappropriate behaviors, and in the language variants, I usually put people on it very soon because it reduces their frustration. Plus, having this, the frontotemporal patients don't always get depressed. The language patients nearly always do, and so you can use antidepressants to treat depression. Atypical antipsychotics can help with agitation, impulsivity, and paranoia. We have to be careful because these patients are not as sensitive as the Lewy body patients, but still can be very sensitive. You just have to start with very low doses. And you have to talk to people about the risk of death. Now, most of the patients who end up on antipsychotics, it's because their quality of life is so bad and the quality of the caregiver's life is so bad that we use them so that they can be taken care of. Memory medications, the memantine or Namenda can help with behaviors, may help some with cognition. There's not much evidence that the cholinesterase inhibitors, which are Aricept, Exelon, and galantamine, or donepezil is the generic name for Aricept, that those are very helpful with cognition, but they may help behaviors. Mood stabilizers, Topamax and Depakote are both seizure medications. There's been one study in Topamax, or with Topamax and FTD that showed some efficacy. Depakote is actually a drug I like to use in my patients with agitation. Lithium, we use in bipolar disorder. I don't usually like to use it in older people unless they've been on it for a long time because of potential toxicities. Sometimes we use Ritalin to try to help with people who just really won't do anything. And the problem is that you don't want to increase any agitation. Antihypertensives are also something we use rarely for people with really refractory agitation because if you drop their blood pressure, they're more likely to fall down. When men are sexually inappropriate, there have probably been about 3 or 4 patients in the last 20 years where I've used this. One of my geriatric psychiatrist colleagues talked to me about using estrogen, but we decided that progesterone is better because it's not as likely to give people blood clots. A little Depo-Provera can be very useful in somebody who has sexually inappropriate behavior you can't control any other way. Now, the caregivers have a tremendous amount of responsibility for taking care of people with FTD. There's providing structure in the home so things are where they need to be so people can remember where to find them. Providing structure through the day. You get up around the same time. Then you go to the bathroom and brush your teeth and go to the bath and urinate. Then you go have breakfast and take your medicine. Then you sit in the chair for half an hour. Then you get up and do exercise. Patterned days make things go better for all patients with dementia, and particularly since they can't organize for people with FTD. Providing a safe environment and monitoring safety. Driving is a huge issue. Driving is something to be addressed with everyone as they age, particularly people with dementia, and people with FTD who might be impulsive and have bad judgment probably have to give up their driving privileges earlier than people with something like Alzheimer's disease. Monitoring medication, monitoring personal interactions so the wrong person, or so the patient doesn't say the wrong thing to the wrong person. And then to encourage activities. Again, sometimes this is really hard, especially later in the disease. So caregivers have to be profoundly flexible. And this is true not only of family caregivers, but of professional caregivers as well. So family caregivers need to partner with a professional team. And professional caregivers all need to communicate with each other. I think it's one of the things that we do worst, certainly among doctors. We're horrible about communicating with each other. And I'm sometimes surprised by the fact that I'll get to my office on a Monday and somebody will have been faxing me about a patient since Friday night. I don't go to the office on Saturday or Sunday unless there's something very, very bad happening that I know about. But I might have six faxes with the same thing on it. No one has picked up the phone to call me. There are just all these faxes letting me know that things have been horrible for 2 days for my patient. So communication is something we need to work with. This is an example of a diary for a caregiver to identify symptoms. So it has the symptom, the date and time that the symptom started and stopped. And by symptom, I mean something like maybe up at night, getting dressed to go to work, or shouted obscenities at my grandson's school musical. You write down what that is, write the situation, what was going on, how much does it bother the patient? Sometimes it doesn't bother the patient at all. How much does it bother the caregiver? This is huge. We want these people to get good care, so we have to take care of the caregivers as well. Did anything make it better? Did anything make it worse? And this is something I found, Jika had written an article about this, talking about how caregivers can help figure out what's going to work best for patients. So keeping a diary is very helpful. And in facilities, I know there's behavior charting, but at home, we often don't have this stuff. Use the diary to identify which symptoms you want to intervene with, because you probably can't do everything at once. We need to be careful to not say, oh, mom is so much worse now and she just started that medicine. You have to figure out, was there something else that made her worse? Really try to tease out, was it just the medicine? We like to blame medicines, especially me. I'm a geriatrician. I like to take people off medicines. But we need to be careful to think about whether the medicine is really helping or hurting. We just pick one symptom at a time and change only one medicine at a time. And it takes a long time for some of these medicines to work. It may take days to find out if an antipsychotic works. It may take weeks. Well, it will take weeks to tell what an SSRI is going to do for you. It may take months to tell what a memory medicine is going to do for you. And you can't say after you first try the lowest dose to avoid side effects that something doesn't work. And you have to remember the disease changes. So medicines that didn't work might, medicines that did work might not. And stopping a medicine may be as helpful as adding a new one. So especially caregivers have a hard time with the transition in roles that they experience as their loved one goes through any kind of dementing process. And I know it happens with professionals as well, especially in facilities where they're the ones taking care of people day in and day out, week after week, year after year. So it's very important that we all help support the caregivers. I listed a few resources that will be available online for people who want to talk about FTD. And I'm going to stop, and I'm sure I'm over time, and I'm sorry. Thank you all.
Thank you, Dr. Reilly. Before we have our next presenter, we're going to just take a short 5-minute break, and then we will resume, and we'll have Dr. Murman speak about Huntington's disease. So help yourself, refill your coffee out there. See you in about 5. Dr. Daniel Murman is a neurologist with University of Nebraska Medical Center, and he's going to present on Huntington's disease. So Dr. Murman, thank you.
Thanks for having me. This next half an hour, we're going to focus on Huntington's disease. Huntington's disease is a much less common disorder, but it's unforgettable if you care for someone with Huntington's disease or if you had a family member that has it. You're going to find that there's a lot of overlap with my talk with the last 2 talks. Huntington's disease has this combination of problems with movement. There's a lot of changes in thinking, but they're more these frontal lobe type problems. And then there's a lot of psychiatric symptoms. So it's sort of all 3 areas are involved and a lot of overlap with the last 2 talks. Anna had mentioned to me that they had done a survey of Hillcrest professional caregivers of sort of what topics they wanted to hear, and Huntington's disease was something that people wanted to know more about, to understand how to care for somebody with Huntington's disease, what's part of the disease, and sort of how to approach it. So that'll be the focus. I don't have any conflicts of interest related to the topic, and this was a resource guide that's been very helpful for me. There's sort of a physician's or a sort of a a provider's guide to Huntington's disease that's updated through the Huntington's Disease Society of America. That's a very good resource. So this is a genetic disease, 100% genetic. If you get this disease, you have this genetic mutation. And we'll talk about some of the details of the genetics of Huntington's disease. So you don't get Huntington's disease unless you have this genetic mutation. As I mentioned, it causes problems with movements. This time it's extra movements, the opposite of Parkinson's disease. These patients can't control their movements and their limbs. We call it chorea when there's a quick kind of involuntary movement. They get some other movement disorders, too, that we'll talk about. They do have trouble with balance, eventually trouble with swallowing. They develop dementia. The dementia has subcortical features and frontal features, and those overlap with, again, the two talks you heard earlier. And then psychiatric symptoms are very common in Huntington's disease. So let's talk a little bit, just some bullet points, some facts about Huntington's disease. You know, it's a bell-shaped curve as far as age of onset, but the peak is right around age 35 to 45. So these are going to be younger patients. And if they end up in long-term care settings, they often are quite a bit younger than a lot of the other patients you're taking care of. So bell-shaped curves, the range is quite extreme. There is a pediatric form of Huntington's disease with childhood onset, and it can develop late in life. Usually if it develops quite late in life in someone's 70s or 80s, it's usually a milder form of Huntington's and often doesn't progress as quickly. We'll talk a little bit about why that is. These patients, even after it's clear they have this disorder and have a lot of abnormal movements, they typically live a long time, on average about 20 years from when it's clear they have symptoms. Now, a lot of the interesting research in Huntington's disease is looking at kind of preclinical changes or very early changes before they have the chorea and the movement disorder. And there are subtle cognitive changes that probably happen a decade or more before you might be able to diagnose somebody. But once it's clear that they have the abnormal movements, it's still 20 years after that that someone would continue to suffer from and have this disease. Again, it's a rare disorder, so if we kind of extrapolate these numbers, 5 to 10 patients per 100,000 population, that would be about 100 to 200 in the state of Nebraska. But what typically happens with Huntington's disease, you may get a significant concentration of patients with Huntington's that's much above these numbers in a given area. So the most extreme example of this is in Venezuela, where there's these very large families that didn't leave the area and continue to stay in that area, and close to 30% of that population has Huntington's disease in Venezuela. So this was actually the site where a series of researchers from across the world went, examined these patients, drew blood, and eventually identified the gene that causes Huntington's disease and continued to do a lot of research in this kind of highly concentrated area of the world that has a lot of Huntington's disease. So let's talk a little bit about how the genetics works. Medically, we call it autosomal dominant inheritance. And that means if you have the abnormal gene, on average, you pass it on to roughly half of your offspring. It's not always half, but roughly half, about a 50-50 chance of passing it on. If you did not inherit the gene, if you're a child of a person with Huntington's disease and don't carry the gene, then your offspring won't get the disease. So it isn't passed on. It's just if you inherit the gene. They now know where the gene is. It's on chromosome 4. The name of the gene is Huntington gene. And it has this repeating sequence of DNA that's longer than it should be. So if CAG is the DNA sequence that's expanded, and that disrupts the function of the gene. Genes make proteins, and really exactly how it causes degeneration and death of neurons in the disease isn't well understood. But that's how you diagnose Huntington's disease. Blood tests, genetic tests for this gene, and count the number of repeats that they have in this segment of the gene. And if it's above 40, then that would be a definite, fully expressed kind of Huntington's disease. And in this sort of 36 to 40 range is sort of an intermediate area. And if it's less than that, then they would not have an abnormality in the gene. Because we know the gene, it's something that can be tested for in somebody that you're seeing that looks like they have Huntington's disease to confirm the diagnosis. But in families with Huntington's disease, if they choose to, they could be diagnosed before they have any symptoms. So pre-symptomatic testing can be done, and that's true in other genetic disorders. But it needs to be done in the setting of genetic counseling with people that have expertise in understanding the disease, understanding how to counsel and help people with the information either way. It's interesting, sometimes not carrying the gene can have a big emotional impact as well as carrying the gene. So it's sort of how would you cope with what changes in your decision making and future pursuits would you do if you did or did not carry the gene. And it's interesting, the number of people that get pre-symptomatically tested is actually very small. Only 10 to 20% of people choose, that are at risk, choose to be tested. So this is just pictorially trying to show you this autosomal dominant inheritance. So when this is colored in, this is a woman. The women are circles, the men are squares. So this person has Huntington's disease. This mother had Huntington's disease, and they had 4 children here. So they had 3 boys and a girl. And this oldest boy has the Huntington's disease and this youngest girl. But it ended up being 2 of the 4 children. Now this this son that didn't inherit it got married, and their children will not pass on the gene. He doesn't have the genetic mutation. But this oldest son that does got married, and now one of his 3 children have developed Huntington's disease. So this is kind of how it can be passed on to women or men equally in this type of an inheritance. Now this is kind of a stylized picture of what a gene looks like. So this is the chromosome 4. This is the tiny area here on the tip of it where this Huntington gene is at. This is a blow-up of the DNA sequence, and there's a region in this gene where the CAG, repeating nucleic acid sequence, is expanded. So up to 30 would be quite normal, and that gene functions normally. But as it expands and this region gets bigger, it starts to disrupt the function of that gene. So there's an intermediate state where we kind of call them carriers, where it's not a full mutation. And there are interesting research. They may have very subtle symptoms, and a lot of times these may be the patients that live to their 70s before they get symptoms, and their symptoms may be quite mild. One of the things that researchers have found, the bigger the repeat sequence, kind of the more severe the symptoms are and the earlier the onset. So those pediatric cases are the ones that have a very large expansion of the CAG region, and they develop symptoms at a very young age. So conversely, the ones that have a kind of either pre-mutation or a low number of repeats certainly may get symptoms at a later age and be milder than others. That's this age of onset concept. There's this other interesting genetic phenomenon that happens in other diseases, these repeat sequences that expand, is in each generation there's a chance for this repeat number to expand. And it's called anticipation, but it means that if you were somebody that had Huntington's disease at age 60, your offspring actually may get symptoms at an earlier age because as the gene was passed on, the expansion happens. And it's a little more likely to expand for a man carrying the gene, passing on the gene, than a woman. So this anticipation is sort of what happens, and that's sort of how this pediatric form happens, that with subsequent generation, that expansion is getting bigger, and then the symptoms are getting earlier in that affected person. So this is kind of the end of the road of 2 sections of brain, sort of cut down the middle. And this would be the Huntington's patient here on your left, and then a normal brain on the right. And there's 2 big areas involved. So this group of little darker colored areas of the brain is the basal ganglia. This is a part of the brain that helps coordinate our movements. This is a part of the brain that's involved in Parkinson's or PSP. But in Huntington's disease, this small little area here called the caudate nucleus is very much involved. So if you look on the left-hand side, that nucleus is pretty much gone. It should be right here going into the ventricle. So the caudate nucleus is very much a part of this disorder and kind of produces the chorea and these extra movements, abnormal movements. But it's also pretty clear that the entire brain is smaller in size, so there is atrophy. And I'll show you a different picture that shows the frontal lobes and the temporal lobes are very much involved in Huntington's disease. So this has subcortical, below the cortex, basal ganglia changes, and it has cortical changes as a part of the abnormal gene, abnormal proteins, and degeneration. This is a PET scan measuring glucose use in a Huntington's patient, and this is a color scale, but in this scale, the bright colors are areas where there's normal activity, normal blood flow, normal brain activity. Those two are tightly linked together, more brain activity, more blood flow. So if you look here, this is kind of what you would expect toward the back of the head here. This is the front part of the brain. So in this bottom row, you see quite a bit of reduction of these frontal lobe areas, meaning the frontal lobes are not functioning at normal capacity. And down here, deeper, this is a temporal lobe that reduced activity. So frontal temporal type symptoms, and you'll kind of notice a recurring theme, much like Dr. Reilly's talk. Many, if not really all of those symptoms, both cognitively and psychiatrically, we're going to review again of sort of frontal temporal type symptoms in Huntington's disease. Again, three big areas: disruption of movement, motor function, swallowing, balance is a big part of Huntington's disease. We're going to talk about a lot of changes in thinking, cognition, and then a lot of psychiatric symptoms. And this combination is really challenging for caregivers, whether they're family or professional caregivers, and they really lead to increasing disability and need for increasing dependence or need for assistance from other people. So help with movements and walking, help with their thinking problems, and help with their psychiatric symptoms. And I would say a majority of patients eventually do need professional caregiving. They're younger patients. They tend not to go to the nursing home quickly, so they'll try to receive care at home for a long time, but there's a real need for getting additional care and help, and families really aren't equipped and can't provide the level of care that these patients will need as they progress. So I'm going to try to test technology and whether this is going to work, but I'm going to show you a couple videos of just the movements. They're very old videos, but we'll just show you what Korea looks like. It's hard to describe. I think a video kind of picture tells 1,000 words of sort of what this is. So let's see if we can get this to go.
Prominent choreiform movements are evident in the left upper and left lower extremity, more distally than proximally. Dyskinetic movements involving the left side of the face and head turning toward the left can also be discerned.
So I would say that's actually quite subtle. So it's just this left-handed kind of movement that she doesn't have complete control of. It's a little worse on the left than the right, a little more in her hands than in her shoulder. So that's a milder sort of a picture of Korea. And then you begin to see quite a bit more of a kind of a moderate stage. This next woman, even her body posture as well as her movements are more involved. So this is just more of the same and sort of a more severely affected.
A patient with Huntington's disease displays generalized choreiform movements. She attempts to incorporate some involuntary movements in seemingly purposeful activity and to suppress other movements.
So this is sort of the progression. At first, patients look like they're just fidgety. They may cross their legs more than you might expect, just to have some movements. And what they're mentioning here is a common phenomenon of just trying to act like you were trying to do that movement, incorporate it into a kind of a purposeful movement, but eventually it gets too hard to kind of mask it. The movements really affect walking. Balance is affected just by itself, but these movements will throw people off balance. And at the end, I'll try to show you a clip from YouTube, and you'll kind of see how it affects his walking. So these are just a list of some of these movement problems. Korea, you've seen a couple examples of. That's sort of the hallmark. That's what the disorder is named after. But commonly, there's a lot of difficulties with speech. So the speech is slurred and eventually very difficult to understand patients with Huntington's disease. Swallowing's involved, and this can be quite dangerous, but a lot of difficulty with swallowing. A little bit of the swallowing problem is both cognitive and motor. So there's impulsivity, and a lot of times patients will try to eat too quickly and too much, too fast, but also they have movement, motor problems with swallowing. So choking is common. Aspiration is certainly a risk. Dystonia is a different movement disorder. Torticollis is a form of dystonia, kind of wry neck or kind of a fixed posture, but it's besides these slow kind of writhing movements, there may be kind of a cramping type holding of a limb and a hand in a posture or the neck. So dystonia is pretty common also. Balance is affected over and above these movements, and it's challenging. So there's a high fall risk for sure for patients with Huntington's disease. So there are some medications that may help a little bit with the movements. Amantadine is used in a lot of different ways. It's used for Parkinson's disease. It sometimes speeds up cognition, but it also has some anti-chorea properties, so it may quiet things down. It's not real potent, but it's pretty safe. It's usually given twice a day. The only FDA-approved medication for chorea is tetrabenazine. It's only been out in the States for a short time, but it's been used in Europe for a long time. And it's a little bit challenging. They have sort of one pharmacy in the whole United States, a central pharmacy that you have to get the medicine through, but the drug reps will help you kind of get hooked up with the central pharmacy. So the generic name is tetrabenazine. It's quite expensive, but they have a pretty generous kind of patient assistance program. It's called an orphan drug, sort of. There's not that many people that use it, and that's how they justify the high cost. But the xenazine can be helpful, usually given 2 or 3 times a day. And as you increase the dose, usually you can quiet down these extra involuntary movements. It's not going to help their balance, for example. It's not going to help their swallowing. And one theme is these last 2 drugs are actually decreasing dopamine activity in the brain. So tetrabenazine sort of depletes in the neuron that's going to release dopamine as its signal. It's kind of depleting in that presynaptic neuron. And then it is true that the dopamine receptor blockers, these antipsychotic medications, do decrease chorea also. But as you begin to shut down dopamine activity, then you're going to get Parkinsonian, as you heard about from Dr. Hoffnung, so stiff and slow, potentially tremor. So too much tetrabenazine is going to kind of make these patients more Parkinsonian. But it is an effective medication to kind of decrease some of their extra movements. One of the biggest, I guess, dangers or thing to be aware of, this tetrabenazine depletes dopamine, but it also depletes 2 other neurotransmitters that are related, and one's norepinephrine and one's serotonin. So one of the biggest potential side effects of tetrabenazine is increased depression. So we'll talk in a little bit that depression is quite common. So that's something that if someone is very depressed, you wouldn't want to start them on it, and once you start it, you need to be very aware of making sure the depression isn't exacerbated. And these antipsychotics can be used both for behavior and movements, but as we've heard before, there certainly are risks of these antipsychotic medications in the elderly. So when we move to the cognitive symptoms, these are the big areas involved. There is a change in memory. It's different than Alzheimer's, and I'll explain that. There are some changes in perception, which can be quite profound. One of the biggest things is this impaired executive function, and these are all these frontal lobe functions that we heard about with Dr. Reilly. There are some language changes also. So the memory, there's 2 kind of unique things about Huntington's that's interesting. One is this idea, there's something called implicit memory. Sometimes you hear muscle memory. There's some activities that you do that your brain does remember, but you can't tell somebody that you've learned it. But one example would be kind of playing piano. There's a variety of movements that go there that you remember how to do. And interestingly, in Alzheimer's disease, that muscle memory or kind of that memory for how to play the piano can be quite preserved. It's still there. But it is affected in Huntington's disease. So there's sort of a breakdown of these complicated activities that we do that involve a lot of movement that we do remember how to do by practicing, that can be a problem. So the other example would be driving. I think each of us know that we don't consciously think about a lot of driving. After you've done driving for a long time, there's a variety of things you do that you can talk on your cell phone, you can listen to music and do a variety of things that you're really not fully engaged in driving. Well, that's a problem in Huntington's disease because they really do need to use their conscious memory and thinking to do that activity well. And if they're distracted, they're going to have trouble. So they can't just rely on the automatic part of driving to be able to function well. They have a problem similar to the Lewy body patients that they can learn new things better than an Alzheimer's patient. but they have trouble retrieving information. So if you ask them something that they recently learned, they may not be able to tell you, but if you give them a multiple choice question, they know the answer, they just can't come up with it. So it's this retrieval that's more impaired than learning new things. Some of these changes in perception, I think the second one's probably the biggest one. There's commonly a significant disruption of insight. So they're not aware of how much they've changed, how much this is affecting them and affecting those around them. So this kind of disease unawareness can be profound and challenging. There's some interesting research that Huntington's patients can't look at a face and judge the emotion that it's portraying. So sort of the visual, non-verbal aspects of recognition of emotion. So facial recognition of the emotion they're portraying is something that neuropsychologists have been able to find. A similar type of thing that's subtle, but neuropsychologists have found perception of time is disrupted in Huntington's disease. So their internal clock isn't working normally. And there can be some spatial perception problems. So the next big area is this executive cognitive function. And I guess simplistically, this is frontal lobe function or subcortical frontal function. So we've heard about attention, planning, organization, speed of processing, initiation, perseveration, repeating things over and over, and impulsivity, which can be a big problem in Huntington's patients. So I just have a few pictures. This would be sort of an example of trying to put together a Lego type structure that my kids did when they were younger. That's a real challenge, being able to kind of look at the directions, look at all the pieces you have, figure out the steps you're going to have to take, what you're going to do first. And we heard about cooking, just all the things that need to go into cooking. And this picture here is just saying someone with Huntington's disease can't be doing 2, 3, 4 things at once. That's not going to work well. So they want to focus on one thing at a time because their ability to multitask is significantly disrupted. And decision-making is a problem, too. Very indecisive and hard to make decisions. Language changes. There can be some difficulties finding the right word. There is some trouble initiating conversations, kind of organizing what they're thinking to express themselves. Eventually, this dysarthria, this articulation, the motor aspect of speech and language is involved, too. But relatively, understanding language is more preserved, so they have better comprehension of language. So there has been no medication that's really been shown to have a big effect on cognition. We don't have any medications that's really been helpful. If there's a lot of psychiatric symptoms going on, treating those can sometimes help cognition secondarily, especially things like depression. The opposite's true. There are some medications that we know is detrimental to cognition, like disrupting acetylcholine function. Anticholinergic medications will make things worse, so avoiding medications is typically the approach. But I have a few slides of just sort of common sense things that I think professional caregivers can think about of ways to approach the cognitive symptoms, both in frontotemporal dementia and in Huntington's disease. It's useful to kind of, this multiple choice idea of sort of giving choices, clues when you're asking questions, or even yes-no answers, because they may not be able to sort of answer, come up with the words or the answer, but they're much better able to if you give them a couple choices or a yes-no question. They're going to need some reminders to initiate activities. Schedules are useful and to help them keep on a schedule. But you need to kind of avoid time pressures. You need to give them enough time to answer, give them enough time to do activities, and the time pressures can only make things worse. You're not going to overcome this lack of insight, so it's probably better to avoid trying to convince them that they have Huntington's disease and they can't do this because of Huntington's disease, and just stick to the task at hand or the behavior you're trying to change. This global insight into the disease probably isn't going to happen. Focus on one thing at a time, provide some structures and routines. That will go much better because of their inability to impose that internal structure on their days and activities. And the biggie is sort of limiting distractions. We need to kind of do one thing at a time, avoid a lot of distracting activities, and things will go better. So this is a list of psychiatric symptoms, and the irritability is very common. Lack of initiative and apathy is very common. Depression is common. And depression coupled with several things. depression coupled with this impulsivity, and then depression coupled with the fact that many of these patients that have Huntington's have cared for their mother or father at the end stages of disease also. So suicide rates are actually quite high. What's interesting, like in Parkinson's disease, depression is very common, but suicide rates are not. So it's sort of this combination of probably a social and experiential experience of taking care of their loved ones into advanced dementia, and then impulsivity, depression, and then the other is a high rate of substance abuse. So a combination of alcohol, for example, abuse, being depressed, kind of knowing where their disease is going, and being impulsive. So we can fix and focus. Being aware of that is very important. So try to treat depression. Try to see if you can control or limit substance abuse would be key, and trying to help quality of life so that they maximize their quality of life while they suffer from the disease. OCD is rare, relatively rare, 20%, but can be pretty severe. So repetitive activities, hand washing, other repetitive compulsions can be a big problem. Actually, hallucinating would be uncommon, so visual hallucination, for example, would not be expected in Huntington's disease. So the non-pharmacological approaches to kind of problematic behavior or these psychiatric symptoms definitely apply to Huntington's as they would really to any patients with dementia and psychiatric symptoms. Try to figure out what's triggering some of the negative behavior, see if you can modify those triggers, and then the other side, see if you can alter how you react to the behavior or how people around them react to the behavior. Try to prevent escalation. So if there's this irritability, and if you can redirect them or try to diffuse the situation, certainly would be appropriate. So sort of the strategies you've learned in caregiving to work with problematic behaviors would certainly apply to Huntington's, trying to alter the environment that's less likely to produce sort of negative psychiatric symptoms. I think Dr. Reilly's summary of the different medications out there for kind of frontal behaviors is really the best summary. So antidepressants, antipsychotics, mood stabilizers can all be used, low doses, one medicine at a time, to try to control some of these symptoms. So this irritability, obsessive-compulsive type symptoms, the antidepressant medicines, the SSRIs, are quite effective at controlling those. For emotional lability and irritability, sometimes mood stabilizers, some of the anticonvulsants, Depakote, Lamictal might be helpful. The SSRIs are good for anxieties. If there's agitated and aggressive behavior, we may need to use these atypical antipsychotic medicines. And again, those will probably help with the movements also. So because some of you are involved in sort of the end-of-life care of patients with dementia, this is just a list of sort of where this disease can go. And the idea of palliative care is very appropriate for Huntington's patients, and some may choose to be in a hospice situation. But weight loss is very much a part of the disease, sometimes due to all the extra movements, but probably even more at a basic level that weight loss is a big problem. It's a way to kind of monitor care. And then choking and aspiration, high risk. Speech therapy involvement is key, and trying to prevent aspiration. Falls and fractures are very common. And again, physical therapy and trying to avoid falls and fractures. But eventually, most patients will end up being immobile, and the complications of being bedridden, and infections are common at end stages. So it would be similar to many of the dementias, but again, these are younger patients that are going to have disease for a very long time, but at the end, they'll have some of these complications of sort of terminal end-stage dementia. So I have just one more thing I wanted to show you. There's a short 1.5-minute kind of video clip from YouTube that I think will kind of summarize everything I tried to get across. It's a very touching short clip that a brother made of his brother with Huntington's disease. So we'll see if we can get this to work.
Huntington's makes it hard for me to walk. Killing me. Because of Ph.D, my brother has to shape it. Hello, my name is Daniel Mundy. I'm 33, and I was diagnosed in 97. And I have a daughter. His name is Kayla, who is at risk, which means she has a 50-50 chance of getting the disease. And I love her. And she's the reason why I have hope. You can help cure Huntington's disease.
All right, thank you very much. Yeah.
Wasn't that a most moving video, everyone? Really, to put a face in a picture with that disease? Very informative. Thank you. Thank you, Dr. Murman. Next up, we have Dr. T. Scott Deasing, a neurologist with Nebraska Methodist Health System, and he will be talking about supranuclear palsy. So, Dr. Deasing, welcome and thank you.
Thank you very much. Can you hear me okay? So I wish after the talks you've heard this morning, I was up here talking about some condition that's benign, treatable, and has a happy ending, but unfortunately, I'm not. Progressive supranuclear palsy, or what I'm going to refer to as PSP for the sake of brevity, much like the other conditions, is poorly treatable, progressive, and ultimately fatal. A few disclosures. As stated, I have a practice out on 90th and Dodge. I work part-time through the general neurology section at the university. I have no conflicts to disclose except for bad grammar. I don't get any money from industry. Nobody's paying for me for my thoughts, unfortunately. And we're going to talk about some off-label uses of medication. So PSP was originally described in 1964 as Steele-Richardson-Olszewski syndrome, and as neurologists like to do at the time, they named it after the people that initially described it, and as we become smarter, we came up with easier to remember, more generic names. It's a degenerative condition predominantly affecting cognition, posture, and eye movements. It's one of the so-called Parkinson's plus disorders, as you've heard about. And as we teach the medical students, think of it as a little bit of Parkinson's plus some additional features, so such as Lewy body dementia, corticobasal degeneration, multi-system atrophy, make up the majority of the so-called Parkinson's plus conditions. It's uncommon. It's not rare, but it's uncommon, and I would venture that most of us have seen a case whether we recognize it or not. It's not uncommonly misdiagnosed. Males are slightly more affected than females for unclear reasons, and it makes up approximately 5% of all Parkinsonian conditions or Parkinsonian patients. Parkinsonian, of course, meaning people with features of Parkinson's disease, not necessarily those with the disease itself. Bradykinesia, postural instability, rigidity, tremor, etc. the condition is, as I said, often misdiagnosed or underdiagnosed, and it's often about 3 years before the patients come to attention or correctly diagnosed. The key feature, which we're going to go over repeatedly, is trouble walking, and half of them will need help walking within 3 years, about the time they present for diagnosis, hence one of the more common presenting features. The condition is, by itself, not necessarily fatal, but usually leads to a very high mortality within 6 years on average, although, of course, a wide range. And the cause of death usually has to do with immobility, infected bed sores, pneumonia, blood clots, etc. What causes it? Predominantly bad luck. There are genetic cases, familial cases, but they're extraordinarily rare. It's almost always sporadic. It has to do with an accumulation of the tau protein in the brain into tangles, much like other so-called tauopathies, Alzheimer's, frontotemporal dementia, PICS, CBD, and chronic traumatic encephalopathy, as is seen in some football players and boxers. It's a subcortical disease. The cortex is not predominantly affected early on. It cuts off down there. Alzheimer's has been talked about as predominantly a cortical phenomenon. But the brain stem and the basal ganglia are the main sites of injury. As stated, falls, trouble walking is the initial presentation in most cases, often before anything else, although some patients will present with trouble speaking, Parkinsonism or bradykinesia, and visual disturbances. It's not uncommon that I'll see a patient in the hospital or a patient referred to me from somewhere for uncontrolled Parkinson's disease or suboptimally controlled Parkinson's disease, and the family comes with them and they wheel them in a wheelchair. They got a little bit of tremor, maybe they're a little slow, a little stiff, but they're in a wheelchair. And you ask, well, how come you can't walk? Well, it's my Parkinson's disease. It may not be true Parkinson's disease if the walking is affected first. Supranuclear ophthalmoplegia, which we're going to come back to, which is an impairment of eye movements, unique, well, very characteristic of PSP. Falls and postural instability, again, the other key feature. Cervical dystonia, especially retrocollis. And the most common cervical dystonia is torticollis, or a rotation of the head one way or the other. But in PSP, they often get a retrocollis, where their head tilts back. Parkinsonism, of course, bradykinesia, postural instability, rigidity, tremor. And then cognitive and behavioral changes typically will occur later. Dystonia is, Dr. Murman had mentioned earlier, blepharospasm or abnormal movements of the eyelids. Apraxia, which is defined as the loss of ability to perform, to learn purposeful motor tasks. So the strength is there, the coordination is there, the sensation is there, but they can't do it. Such as loss of the ability to brush your teeth, to count your fingers off, to make the OK sign, etc. Bladder control loss can occur. Speech apraxia or a non-fluent type aphasia can occur. So for the next hour, I'm going to go through each of these nuclei. I'm a neurologist. I love neuroanatomy. I'm not going to go through any of this. But I will point out there is an interesting correlation because the vertical eye movements, which we're going to talk about in a minute, are affected predominantly. One interesting feature is that the vertical eye movements have to do with a tract that goes up the brainstem to the midbrain as opposed to the horizontal movements, which are down lower, and the basic eye movements, which are down lower. And because the midbrain is predominantly affected, that leads to the characteristic gaze palsy. Although, if you want, I can go through this at length. I'd love to talk about this stuff. So the supranuclear ophthalmoplegia is the inability to voluntarily move the eyes, typically in the vertical plane. So moving left and right is usually spared early on. Up and down is impaired. Now, as we all age, we all lose some ability for up gaze. That's not unusual. But down gaze is very characteristic of PSP. Doll's eyes are maintained. They can do involuntary movement down, but if you ask them to do it, they can't get the message to the brainstem correctly to move. Early on, you'll see square wave jerks or rapid herky-jerky movement of the eyes or delayed initiation. Now, cut off the bottom, so it must not be important. So the nuclei, or the main centers for moving the eyes inside the brainstem, are intact. So with doll's eyes are intact. If you have somebody who's semi-conscious or unconscious, and you take their head and roll it one way or the other, their eyes stay relatively fixed on a point. That's still intact in PSP early on. Bell's phenomenon is similar. Bell's phenomenon is when you close your eyes, your eyeballs actually roll up a little bit, which is partially why when somebody faints or passes out, their eyes, quote, roll back in their head. And that's maintained. Although, again, you ask them to look up or down, and they stare straight at you. They can have trouble with lid retraction, where their eyes seem very prominent. Their eyes are up. They have a delayed closure of the eye. They can have eyelid apraxia, where they'll blink as anybody does involuntarily. You ask them to blink or close their eyes, and they can't do it. Blepharospasm or eyelid spasms, as mentioned, and they can have convergence insufficiency. So when they look at near objects, they see double. Not blurry, but double. They see two images. Falls and postural instability, of course, the earliest feature in most cases, usually in the first year of onset. And again, as we teach the medical students, if you see somebody who has Parkinsonism or Parkinson's-like symptoms, and they're falling down or having trouble walking early on, really think about PSP as a diagnosis. Their walking is wide-based, like somebody who's ataxic or drunk, but they fall in any direction. Now, people with Parkinson's disease, although they can fall in any direction too, front and back tend to be more prominent, especially if they have freezing where their feet seem to stick to the floor. Whereas people with PSP, they'll go down anyway. They're usually a little rigid, just like Parkinson's, but they have relatively little tremor. Now, they can have some tremor as the disease progresses, although usually it's minor in comparison to the other features. Again, as opposed to Parkinson's disease, where tremor can be the presenting symptom. They typically will end up with cognitive or behavioral changes. It's milder than that seen in the other dementias, such as Alzheimer's, although they can have some apathy, trouble with short-term recall, slow processing, poor planning and sequencing, as has already been discussed. They can have trouble thinking abstractly. They'll have imitation behavior. As you're talking to someone with imitation behavior, they'll uncontrollably start to act out what you're doing with your hands. Frontal release signs, such as the palmomental response, where you scratch somebody's base of the thumb and they get a little twitch on their chin. Don't panic. That's normal for a lot of people, but it can be very prominent with some types of dementias, or if it's asymmetric, it's certainly abnormal. And they'll have impaired verbal fluency, as I said. So one of the interesting things about this condition is they get this very characteristic facial expression. And this is usually later in the condition. And this is a classic picture of a lady who has this scared, astonished, worried look. Some people have described it as the reptilian stare. It's almost disconcerting to look at them. There's a degree of bradykinesia. They don't move their face as much as somebody with Parkinson's, but the eyes are very prominent, and the face it looks unhappy. So here are a few other patients, and you can see this gentleman and this lady have a little bit of retrocollis as well, where their neck is extended back somewhat. Notice the mouth is slightly open. There's a little bit of a frown there. Their eyes are wide open. And then the poster child is Dudley Moore, who had the condition, and obviously there's an early picture of him, and here's a picture late in the condition. He's actually receiving an award and trying to smile. His eyes are quite wide. He's got that that scowl on his face, and he's obviously sitting in a wheelchair. So as we talked about a little bit already, there's some overlap with Parkinson's disease, but the two conditions are different and can be differentiated by, again, the early falls and eye movement trouble, as opposed to Parkinson's disease, where that can occur, but typically occurs late. The falling in any direction for PSP, as opposed to front and back for Parkinson's disease, is not as reliable, but an interesting finding. The PSP patients typically have rigidity with little or no tremor, as opposed to Parkinson's disease, which presents most commonly with rigidity and some tremor. If you give them levodopa, Sinemet, carbidopa-levodopa, and they don't respond, that's typically, well, either you're not dosing it correctly, or you've got the wrong diagnosis. And we start thinking of the Parkinson's plus conditions when they don't necessarily respond to levodopa. PSP is no exception. The unofficial fifth cardinal sign of Parkinson's disease is a response to levodopa. Now, people with Parkinson's disease have a relatively good prognosis as compared to PSP. As we talked about, generally they lose ability to walk within 3 years, fatality often within 6 years. It's a very debilitating condition. So in the workup for these patients, they usually get an MRI either before or after they see the neurologist. And this is a cross-section of the brain looking from the side. Here's the nose and the tongue, and this is the top of the spinal cord and the brainstem, the cerebellum, and the hemisphere. So this is right in the middle. This is the pons, and this is where all the cranial nerves come out of here and here. And this is the midbrain, where the brainstem ultimately will connect to the hemispheres. Now, this is shrunken. It's small, and it's actually a little rounded and concave right here, and you get this little beak, what the radiologist will call the hummingbird sign. It's more of a cone, and it's fuller in the normal brain. And again, that's from death or deterioration of those neurons predominantly within the midbrain. There's other tests. Doctors have lots of tests that we can do. Some are helpful, some are not. You can do a sleep study. The patients can have a progressive loss of REM sleep, less REM, delay to REM, or they can have REM behavior disorder, where they act out their dreams. Their brainstem doesn't paralyze them when they're asleep, and it's more than just talking in your sleep or twitching in your sleep. They'll reach over and grab their wife and give her a headlock, or punch somebody, or reach out and grab things. There's studies looking at CSF biomarkers. They're looking at tau subtypes. There's some interesting work being done there right now. It's not practical for the routine evaluation. You can do a fluorodopa PET scan. It gives you really neat pictures. It can help differentiate if you're trying to decide between different types of similar conditions. But again, I don't typically do that in routine practice. It's a clinical diagnosis based on what they tell me and what I see. There's no disease-modifying agents. We don't have anything that slows the condition, stops the condition, or fixes the condition. We do have symptomatic therapy. And even though I told you that most patients don't respond or respond poorly to levodopa, Sinemet, I usually try it. It can't hurt. It usually doesn't hurt. And some people do get some benefit from it. So if I think they're going to benefit, I'll usually try a little bit when they feel that they need it. There's anecdotal reports and some off-label use of tricyclic antidepressants, of course, the atypical neuroleptics, bromocriptine, amantadine, trazodone, and many, many others. Coenzyme Q10, there's been a couple small studies that have looked at coenzyme Q10 for this condition, among any other things. It's a supplement really looking for a purpose, although there's some reports that this can help a little bit. It's benign. It's usually a big pill, and it can be kind of pricey for a supplement, though. Patients very often end up seeing ophthalmology because they have lid retraction, because they don't blink as much, because of their characteristic stare. Their eyes tend to get dry. They can develop infections and abrasions in their cornea. Swallowing usually is affected at some point down the road. Swallowing studies are mandatory. They end up with a modified diet and late in the condition, peg tube if they're in agreement. They almost always need physical therapy, speech therapy, and I have a low threshold to send them to the therapist or even the physiatrist to try and maximize what mobility they have. Canes early on, but usually they'll end up with a walker and a wheelchair at some point. The family, I mean, this is a tough condition to care for, and you're not just treating the patient, you're treating the people in the house with them, especially their spouse. It's very, very frequent that the patients come in to me and they're wheeled in a wheelchair. How you doing? I'm doing great. And I look over and the wife or the spouse has got some kind of back brace on. They're trying to lift their spouse in and out of the chair, onto the toilet, so on and so forth. So they need just as much help. The key points, the takeaway points, looks like Parkinson's disease, inability to walk, abnormal eye movements early on, as opposed to typical Parkinson's disease with tremor and rigidity. Doesn't respond well to carbidopa-levodopa. If they don't respond to the medicine, if they're on superhuman doses of carbidopa-levodopa and they really don't look like they're benefiting from it, it's a possibility. And speech, swallow, physical therapy, evaluations, and treatment are absolutely essential and probably more helpful than anything I do. Thank you for your time.
Thank you, Dr. Deasing. That concludes the panelists' presentations. We're now going to open it up for questions and answers. Does anyone have a question that they want to ask our panel experts? Okay, we have microphone right up here and over here. If we could get you to come up front.
Dr. Deasing, at what point in supranuclear palsy do you see dementia or the cognitive changes?
She's going to check on it right now.
Okay. So you usually will see some cognitive impairment. It's usually not the first presenting symptom, as I showed. A few years into it, you'll start to have some symptoms. Almost universally, by the end of the condition, they'll have some cognitive impairment. It's different for different people. And again, because most people don't even get to the doctor or don't get the diagnosis for years, it's fairly frequent that when we make the diagnosis, there's a little bit of forgetfulness, some short-term recall difficulties, easy confusion, maybe some post-operative delirium, some of the early signs that we see of dementia.
Okay, thank you. And then I had another question. I'm fairly sure that where I'm at, there's some misdiagnosis. Most people have already been diagnosed with Alzheimer's, although I don't think that's probably what some of them actually have. So by this point, you know, they're pretty severe, and we have a participant that has very overt sexual repetitive behaviors. Do you ever see something like that in the very, very late stages of AD? Would you see that even there, or would you, because we don't really have a good prior history of how it started?
Sure, and you bring up a couple of excellent points. First, when people are at the end stage of many kinds of dementia, it's indistinguishable what got them there. Vascular dementia, Alzheimer's disease, frontotemporal dementia, PSP, Lewy body. People end up not being able to move, not being able to talk, and when we try to test them to figure out what got them there, we can't tell. The sexual inappropriateness or aggression can happen with a variety of different disorders. And so again, you probably aren't going to know, and because we have a limited number of medications, you might notice that we all had basically the same medicines on our slides. we end up treating people kind of the same way. Maybe for sexual problems, maybe starting with an SSRI to see if cutting the libido, which is a side effect, which in this case is desirable, will be helpful. You can move on to hormonal therapies or some of it. I mean, there are many things to try.
Thank you.
Other questions in the audience for the panelists? I have one quick one, please. Our family members, I see the commonality of symptoms up there with all the different types of dementia and the Huntington disease and the PSP. What is the best recommendation for family members and caregivers? If you are observing these type of symptoms, do you go to the primaries first? Is that what we're telling our family members? And then having the primary care physicians recommend who they should go see?
I think that's probably the way things will transpire, but I think all 4 talks today, it's probably best to kind of move beyond primary care and try to get a specialist that knows about either the different neurologic conditions or subtypes of dementia. So I think each of these, back to the last comment, that probably more testing and evaluation, especially early in the process, might help subdivide and understand this is different than Parkinson's, for example, or this isn't Alzheimer's. It can be helpful, both understanding and supporting the family and the different medicines. So yeah, I think it sort of depends on what their greatest needs are. I think if there's a lot of medical problems and social issues, geriatrics would be very appropriate. If it looks like it's predominantly a neurologic problem, they'll probably have to see a neurologist that has experience in these disorders, either Parkinson's or dementia.
Thank you.
I was just going to add, in my experience, because I rarely see individuals with Alzheimer's disease because primary care physicians are so good at recognizing and managing the Alzheimer's patients, and I typically only see people who don't fit that typical memory and language difficulties early on. So the more astute primary care physicians are the ones who are saying this isn't typical or typically what I see, or getting this diagnosis is really going to be helpful, but it's a small percentage that make their way to my office that have garden variety Alzheimer's disease.
And I'm sorry, I just want to add that I think it is appropriate to go to the primary care physician first, but if you're not getting what you need, if you say, no, this just isn't fitting right, it is okay to seek other opinions. There aren't any. There used to be insurance reasons you had to go to the primary and get a referral. Those really don't exist at this point. It's important to be the advocate for the patient and say, no, we really need to know what's going on.
Thank you. So a question for Dr. Beeson. How early in PSP would you see?
Nadia, can you step up?
Okay. How early in PSP would you see supranuclear ophthalmoplegia?
It can be the first sign. Typically, it can be the first sign. The problem is it can be very subtle. I mean, people don't just walk in with inability to look down and say, "Doc, I can't look down." What they have is on examination, they'll have a little bit of jerkiness to their eye movements, some inconsistency to the eye movements, or a hesitancy to trying to move in that plane. And the doctors and neurologists should be able to pick it up way before should be able to pick it up early.
Is it like in 100% of the patient with PSP, or could you have PSP and not have that?
You can have, most patients will have it. Obviously, there are other, it's not exclusive to PSP, and there are other conditions where you can have it. Most will have it.
Thank you very much.
I have a twofold question. One is, I'm asked by many families about the heredity of dementia. And I know, Dr. Murman, you talked about Huntington's disease and the particular gene. But in terms of other kinds of dementia, the family's always concerned about passing on, frontal temporal lobe or Lewy body, et cetera. And what would you answer in terms of that question? And then related to that is the longevity of the dementias. I know only God knows our expiration date, but in terms of the length of the disease many times in some of the readings it talks about the actual dementia causing death, whereas more of the readings I've read talk about the diseases that come along with the dementia that actually cause the death.
So I can address the genetic part. Today I think we've seen a whole spectrum of how likely you are to pass on the disorder. So Huntington's is the one that is a genetic disease, and it really only occurs through the genetic abnormality. The frontotemporal dementia, as Dr. Reilly said, in the young patients, it is a third, potentially 30 to 40%. There may be a genetic basis, so that's a pretty big percentage. But overall, the majority are not genetic. DOB is not well understood. There's some associations and maybe some risk factor genes, but strongly genetic. Lewy body disease is quite rare. As Dr. Deasing said, then PSB typically is not genetic. So I guess that's one reason to kind of be specific of what the disease is. The genetics is quite different amongst them. And the two biggies would be Huntington's and the frontotemporal. The one association that's just come out very recently is with frontotemporal, they can have the tau problem and often some Parkinson's features, and PSP is a tau problem. There's also kind of a link with ALS too, and some of those are genetic, where they might have Lou Gehrig's disease and frontotemporal dementia. But then as you move to kind of DLB and the PSP, they're probably not going to pass it on.
And the morbidity question in terms of?
If it's okay, I'll address that because I do hospice work and we have a tremendous number of dementia patients on hospice. And I often sign the death certificates with dementia as the cause of death because that's how they got there. And if I write down starvation or dehydration, then people say, oh, well, this is neglect, somebody wasn't taking care of them. What happens as dementias come to that kind of final common pathway is that you get immobility. People are not eating, not drinking. If you try to force them, they have trouble swallowing. You can wind up with food and drink in their lungs. So people die of pneumonia. A lot of people just kind of wind down and stop. And it's because they've stopped eating, they've stopped drinking, and after a while the body kind of closes down. I think it's not inappropriate to ascribe their deaths to that because if they didn't have the disease, that's not what would have happened. But the actual terminal event can be infection, it can be a blood clot. You're most often talking about an aging population, so they can have strokes and heart attacks, and sudden things happen just like anybody else. But if none of that happens, just kind of closing into themselves and not taking in nourishment and drink is what ends up.
Thank you very much.
Actually, two questions. The first one takes off a little bit on your statement in terms of workup and diagnoses. And you, Dr. Reilly, implied insurance coverage usually isn't a major issue, and probably unless it is for everything else in their health care plan. I guess my question is, related to that, when you're working with a family, you may be working with people very early on, so that it may be hard to diagnose at that point, and so families will frequently say, we've already seen someone, and they say it could be, we don't know for sure, unless it's a genetic thing, versus people who probably were misdiagnosed. And can you speak to the benefit of those two extremes in terms of the timing? Because if it wasn't adequately diagnosed, you can't back up the clock and do it. Should you still do it at that point? And when in the process do you think is the best to refer them for a more detailed workup?
As early as humanly possible. As soon as you notice that there's something different. Because as we refer to and I want to say, the majority of people that you see with changes are going to have Alzheimer's disease. That's the most common disease. Everyone is going to see that. It's important to recognize these other things because of the difference in the prognosis, sometimes in the difference in the treatments, but more for planning at this point. The medicines only stabilize people, and I would much rather stabilize someone with mild cognitive impairment who doesn't even have dementia yet and keep them at that level. We have a lady that we're taking care of now who just had her 90th birthday. Dr. Murman and I were at her birthday party. We diagnosed her with dementia, I think about 8 years ago. She has been incredibly functional and doing really well for 8 years. She now appears to be falling off the cliff, but we had 8 great years, which is much better than waiting until she got to be 88 and wasn't having much of any fun at all and trying to hold her steady there. So it's actually easier to find people early in the disease, especially with the benefit of neuropsychological testing. That very subtle changes can be picked up. So I would much rather say, nope, you look pretty good, which happens once every 2 years. Maybe we'll see somebody who was referred because their kids were and they have normal changes of aging. I would much rather have that happen 10 times than not see people until they're moderately advanced and have to move out of their home and start taking medicines and make huge changes in their lives because we didn't do anything earlier.
I guess that probably plays a key role in my question, because so often people hear, well, we all lose cognitive function. I have problems. You made the comment about, the car keys and forgetting things, and we're not talking about that. But I think there is a little bit of hesitancy because they've been told by medical people, well, we all lose brain function. So give me, more evidence. And if they're not literally living with the older person, they may not have really good additional information. So what about someone who probably you suspect may have been misdiagnosed and they're further advanced? Still recommend the complete workup?
I would say if people can answer questions and still perform some tasks, that it's what do you agree?
I would agree. Neuropsych testing is helpful on many levels because it really gets into the subtle differences. It helps to guide where interventions might be helpful. It can be very reassuring. And it's also a finite or a qualitative manner to show a patient or their family members this is not normal functioning. We compared you to someone your age and your level of education. In a room of 99 people, you'd be in the back. This you had difficulty on, or this is not normal. And being able to differentiate and discriminate, it is meaningful to patients and their families. Knowing what's going on is meaningful to them.
Okay. Then my other question has to do with providing services. A very common theme that I have heard today is if we could do a better job of physical therapy related activities, and not necessarily with the physical therapist, but just really focusing on maintaining the function. Would you agree there, kind of across all of the diseases?
Well, research has showed, I think, that physical activity is one of the primary variables that slows progression from mild cognitive impairment into dementia for the most typical dementias. So when I talk to people and they invariably say, well, what can we do? I say there's really 3 things that we emphasize: physical, social, and mental activity. And that is a big part of it.
My staff, they seem to get the Alzheimer's disease. They don't seem to come to me saying, I'm going to try to change this person or whatever. But when you get the frontal lobe dementias and you see some, even the others, they kind of come to me saying, well, we need to work on her. We need to change her or him. And I'm like, in some ways, I don't know if I should be or shouldn't be. Like with frontal lobe dementia, sometimes I think it does a little bit. If I do like a reward system, if you finish your meal first, then we'll give you dessert, because they'll always start with the dessert kind of thing. But then there's if a family member sees that we're not giving a dessert, then they think, well, why are you withholding something? So I don't know if some kind of behavior mod with those is effective or not effective, or should I not do them, or should I keep trying to do them?
I was just going to make one comment. I think you do need to do the behavioral modification, and I think Dr. Reilly's comment about early developments and even from childhood into teenage years, you need to impose some rules, regulations, structure, and I think that is helpful. The frontal lobe disorders are the hardest for caregivers to deal with. They are kind of socially inappropriate and unpredictable and challenging. And I think one overarching decision maker for you is, are they hurting themselves or somebody else is a big thing you're going to have to continue to think through, but I think they do need structure.
I agree completely. Behavior modification can work with people well into moderate stages of dementia. I had this conversation with a patient's son-in-law yesterday because she is sometimes really mean. And he said, but I had thought, should I say, just knock it off? And I said, well, if you get mad and start yelling, she's going to just get louder and escalate. But it is fine to say, gee, it doesn't seem like we're having a very good time today, or gee, you don't seem like you're very interested in talking to me today. I'm going to go away. I'll be back later, but I'm going to go now. And if those unpleasant behaviors result in the loss of contact, or I think the eat your dinner before you have dessert is entirely appropriate. For people in later stages of the disease, you have to stress to the caregivers that they're the ones who can change. We're not necessarily going to teach somebody if you, you have to do this and this and this. But the behavior modification that is not, you have to do this, so I'll do that. That's not complex, people can get, but the caregivers have to be as flexible as my slide showed as possible.
So I've used both positive and some negative reinforcers in regards to that. Is there, sometimes I always find that the positives are always a little bit better. Sometimes the negatives, maybe aren't as good, especially if they're functional day-to-day activities. And this one I'm particularly thinking of is because she has, sometimes I think she can control her incontinence, and other times I think she can't control her incontinence. And because she'll just, where she has her incontinence at makes you think that she can control it because, she'll actually pull her, product over to the side and just, go somewhere. And so, the staff members, are wanting me to do something, and sometimes maybe it's just makes them feel better, but they, I don't think it hurts her to participate in doing her own laundry. And so when she does do that, they'll say, okay, now Jane, you need to take your stuff, we'll go to the laundry room and do that kind of thing. Kind of more of a negative reinforcer, but saying, if you're going to do this, because they sometimes have to do this, 5-6 times a day, complete bed changes with her. And
well, what we know about behavior modification for animals and people is reinforcement always works better. You always want to increase the behavior that you want, and environmental modification. And so for an individual who's doing something that is undesirable, you make it harder for that behavior to occur, and you reinforce what you want. So positive reinforcement means adding something. So, leaving the adult diaper on gets a reward, or removing something negative. So leaving the adult diaper on means you don't have to eat your vegetables, or just making it difficult to remove the adult diaper by using the same things that we use for children, a onesie or something like that, where it's going to be harder for them to do the behavior that you don't want.
All right, thank you.
I have a quick question on depression for Dr. Reilly. Since you work with an elderly population, how do you discern what is reasonable situational sadness from depression? Because so many of them have had losses, or a spouse will have just died. And I've noticed some physicians will, I'm not judging it, but some will quickly put them on an antidepressant, and some will say, that's a reasonable response to a difficult situation.
Part of it is the time course. And that's variable. But certainly if you're more than a year out from like loss of a spouse or a major change, most of us adapt within a year, but how miserable they are You know, are they just sad when they think about it? Are they distractible? Can they still find pleasure in other things? You know, you can be sad because you had to move out of your house, but still maybe enjoy going to your granddaughter's birthday party. And the chronicity of it. Is it getting better with time? You know, expect things to be terrible right away when there's a big negative change, but a couple weeks later, are things a little bit better? Are you having more happy moments? And if people are miserable and crying all the time, I give them medicine.
And however, I would say that just because a sadness is reasonable, or just because we know why somebody would be upset, doesn't mean that we wouldn't still want to treat depression if it's interfering in their quality of life. Yes, getting older, yes, losing a spouse, moving out of your home, these are events, it makes sense. But depression doesn't mean you're unhappy for no good reason. There are triggering events in depression that is still appropriate to treat with an antidepressant. So you don't just give people antidepressants if they have no good reason to be depressed. You would treat somebody because it interferes in their activities and quality of life.
And I'm sorry, the other symptoms of depression, eating too much or not eating enough, especially sleep disorders, respond very well. And the question that I usually ask, not in people with obvious reasons for situational depression, but I ask people, what do they do for fun? And if people say, boy, I haven't had fun in a long time, that makes my radar really start beeping that there may be something going on there.
Hi. I just have a question regarding we're seeing, or at least I'm seeing, more individuals that are being diagnosed early onset. Is it a commonality that all of you doctors see that when they are diagnosed early onset in their 40s and 50s that they tend to decline a lot quicker? Things change quicker, maybe have a plateau for 6 months and then go on a gradual decline. If you do agree with that, why do you think that is? And is there anything that we could be doing to help these individuals?
So on the early onset, you know, the large group is the Alzheimer's group, at least half, if not more. It does seem to be, I don't know if there's clear scientific evidence, but they do seem to progress a little more quickly, be a little more aggressive than if you develop symptoms in your 80s. So in that sense, they often may have a little more genetic predisposition to get it at such a young age. It does seem to be a little more progressive, aggressive disease. Frontal temporal, again, a lot of these are young patients, and you know, to whether they progress faster than an older frontal temporal patient, they may look different. I think besides the biology, it's a whole different social situation when you're less than age 65. So typically, the main caregiver of the spouse is still working, the patient may still be working, and I think that it's just very challenging to provide the care as they move from mild to moderate disease, that it's easier in one sense if the spouse is home all the time to provide that care if they're 75 or something like that.
Okay, let's give our panel experts one round of applause. Thank you so much. I also want to extend another thanks to Sarah, Michelle, and Cody, and Taylor for taking care of us and meeting our needs. Thank you so much. One last reminder, please, on your CEU forms, you need to have the white one, the white top part is yours. Please make sure you turn in the yellow, as well as with your evaluation at the front door. Cindy, is that what they're doing? Cindy's in the back there. Thank you all for taking the time to share.